Okay, let's just jump right in. Picture this.
The clinic.
Yeah, you're at the bedside, it's a busy morning, and you've got a patient with confirmed Helicobacter pylori.
Standard case, usually.
Totally. Normally, you've got your playbook, right? Probably a clarithromycin-based triple therapy. Done.
You send them on their way.
But then you see it on the chart, that big red flag, a confirmed penicillin allergy.
And that one detail, it changes everything. It completely changes the risk calculus.
How so?
Well, suddenly your primary weapon, amoxicillin, is just off the table.
Right.
So you're not just looking for efficacy anymore. You're, navigating this minefield of potential cross-reactivity, trying to keep those high eradication rates without the backbone of your usual regimen.
Exactly. And for an adult patient, the guidelines pretty much narrow us down to two main options.
The two big contenders.
In one corner, you have the heavy hitter, Bismuth Quadruple therapy, BQT.
And in the other corner, you've got the challenger, the more streamlined one, levofloxacin-based triple therapy, or LTT.
BQT versus LTT. On the surface, it just looks like, complex versus simple.
Right. It's so easy to think, well, obviously the simpler one is better for the patient.
But it's not that simple.
Not at all. I mean, if you really dig into the data, the decision is way more nuanced. You're balancing complexity against local resistance, patient's kidney function, the actual reliability of the cure.
So that's our mission today. We want to move beyond just flipping a coin. We want to really understand when to use the workhorse, BQT, and when it's actually safe, or maybe even better, to switch to levofloxacin.
Because the stakes are high. It's not just about clearing an infection. It's about preventing resistance and avoiding unnecessary toxicity down the line. We have to get it right the first time.
Okay, so let's unpack the default then. Most clinicians in this situation, they're going to instinctively reach for Bismuth Quadruple therapy. Why is that the immediate go-to?
It really comes down to one word: reliability.
The workhorse.
It is the workhorse for a reason. First, and this is the most obvious point, it completely avoids beta-lactam antibiotics. That's the non-negotiable part for a patient with a true penicillin allergy.
So it's structurally safe from the get-go.
Exactly. But beyond that, BQT has a reputation for just being really effective across a huge range of settings.
Even with resistance being a problem.
Especially with resistance. We're in an era of rising antibiotic resistance. To clarithromycin, to levofloxacin, BQT, just by its nature, the bismuth, tetracycline, metronidazole, plus a PPI, it holds up really well, even when levofloxacin resistance might be lurking around.
I find that interesting because it's like a multi-front attack.
It is.
You've got the bismuth coating the stomach, disrupting the cell wall. Then tetracycline hits protein synthesis. Metronidazole messes with the DNA. It's coordinated strike.
That's a perfect way to put it. And because of that, it acts like a safety net. As a clinician, if you prescribe BQT, you can be pretty confident you're balancing efficacy and safety. You don't even need to know the exact local resistance numbers for levofloxacin to feel good about it.
It covers your bases.
It does.
But there is a real hesitation with BQT. I think every one of us has looked at that prescription, at the sheer number of pills, and just paused.
Well, it's a lot. A standard course can be, 14 pills a day, sometimes more.
Yeah, taken 4 times a day. And there's this perception that because it's a quadruple therapy, it must be awful for the patient. But the data doesn't really show that, does it?
That's a super common misconception.
Yeah.
Yes, the pill burden is high, no question. But if you look at the stats on treatment discontinuation, so how many people actually stop the meds?
The dropout rate.
Yeah, the dropout rate isn't statistically higher with BQT compared to other options.
That's amazing, actually.
It is surprising. You'd think it would be. But it turns out, while patients might complain about the number of pills, or maybe the metallic taste from metronidazole, they usually finish it. Adherence isn't just about pill count. It's about motivation and how you counsel them.
Okay, so BQT is the reliable, resistance-proof tank. But then there's the alternative, levofloxacin-based triple therapy, LTT. Why would anyone ever veer away from the tank?
The appeal is obvious. Simplicity.
Right.
LTT is just, it's a much lower pill burden, usually dosed twice a day. So for a patient who's already on 5 other meds, or who just hates taking pills, LTT looks really, really attractive.
It tackles that adherence question head on.
Theoretically, yes.
Yeah.
The logic is, if I give them something simpler, they're more likely to take it all, and we'll get a better outcome.
In a perfect world, sure.
But we don't live in a perfect world. We live in a world with evolving bacteria. And that brings us to the giant, however, the massive catch. The critical weakness of LTT is that its effectiveness is completely tied to susceptibility. If you have local resistance to levofloxacin, and in many places that resistance is climbing fast, LTT just falls apart.
So simplicity doesn't equal efficacy if the bug is just laughing at the drug.
Precisely. That's the trap. You think you're doing the patient a favor by giving them the easy regimen, but if local resistance is high, or even if you just don't know what it is, you're essentially prescribing a placebo with side effects.
And setting them up for failure.
You are. And failing on a fluoroquinolone like levofloxacin is a big deal. You burn a bridge.
Because you might need that class of drugs for something else later.
For a future UTI or pneumonia, you not only fail the H. pylori cure, but you breed resistance that could complicate things down the road.
Okay, so this gets us to the heart of it, the decision matrix. 2 options. How do we choose? It seems like there are 4 big factors here. Let's start with the one you just mentioned. Local resistance.
This is the deal breaker. Factor number 1. If you are practicing in a place where levofloxacin resistance is high, and that's usually defined as over 15%, or this is key if you just don't know the rates, BQT has to be your default.
Full stop.
Full stop. You cannot gamble with LTT in a high resistance or unknown resistance setting. The risk of failure is just too high.
So LTT is only on the table if you know for a fact that local resistance is low.
Exactly. You need the data to back it up.
But that's a challenge, isn't it? I mean, we don't all have a real-time H. pylori antibiogram on our desk.
We usually don't. Culture and sensitivity testing for H. pylori is not routine. It requires an endoscopy, a biopsy. So we're often relying on regional data, maybe hospital antibiograms for other bugs, as a proxy.
So what's the rule of thumb?
If you're not sure, you have to assume resistance exists. Err on the side of caution.
Okay, that's a very clear line in the sand. Factor 2. Adherence and pill burden. You said this is the big selling point for LTT. How much weight should this carry?
It matters, but you have to assess the specific patient. It can't be a blanket assumption. But let's say you have a patient with some cognitive challenges, or a documented history of non-compliance, or they're just drowning in polypharmacy.
Right, trying to manage meds for heart failure, diabetes, and then you want to add a 14-pill regimen on top of that.
Exactly. In those specific cases, the high pill burden of BQT might be a genuine barrier. So if you've already checked factor 1 and resistance is low, then LTT becomes a strategic preferred option.
You're trading a little bit of efficacy for the practical reality that the patient will actually take the medicine.
Because the best drug in the world doesn't work if it stays in the bottle.
True.
But, and I want to stress this, we shouldn't use fear of complexity as a blanket excuse to avoid BQT. Remember what we said about the discontinuation rates? They're similar. Most patients can handle BQT if you explain why it's so important.
Got it. So it's a consideration, but not a free pass. Let's move to factor 3. Patient profile, specifically age and renal function. This feels like an area where the choice gets much clearer.
It does. This is where the safety profiles really start to diverge. If you've got an elderly patient or someone with renal impairment, you have to be extremely cautious with levofloxacin.
Why is that? What's the specific concern?
Fluoroquinolones carry risks that are just amplified in these groups. There's a black box warning for tendinitis and tendon rupture. But beyond that, in the elderly, you see higher risks of neurotoxicity like confusion, delirium, and QT prolongation, which can cause dangerous arrhythmias.
And these are often patients who already have lower renal clearance at baseline.
Precisely. Levofloxacin is cleared by the kidneys. So if your patient has, say, stage 3 CKD, the drug can accumulate, and the risk of those toxicities goes way up.
So for my 75-year-old patient with stage 3 CKD?
You should almost certainly be using BQT to let you minimize those specific risks. Bismuth isn't really absorbed, and while you have to be a bit careful with tetracycline and severe renal failure, BQT generally avoids the big systemic risks you see with fluoroquinolones. It's just safer.
That's a huge clinical pearl. Okay, factor 4, allergy severity. We know both are for penicillin allergic patients. But does the type of allergy, say highs versus anaphylaxis, change the choice between BQT and LTT?
Indirectly, I'd say. A confirmed allergy points you toward BQT as the standard, but you still have to be careful with what's in the BQT.
The other components.
Yeah, the tetracycline, the metronidazole. You have to make sure there's no separate allergy to those. So you can't just auto-prescribe BQT without checking the patient's full history.
Right.
But generally speaking, BQT is designed to be the safe harbor for the beta-lactam allergic patient. It's the regimen that lets you sleep at night.
Let's pivot to what we could call clinical pitfalls. We've got the decision matrix, but where do clinicians trip up? What are the big don't do this items?
The first one is extrapolation. Don't take data from the general population and just blindly apply it to your penicillin allergic patient.
Meaning, you see a study where a certain regimen worked great.
But it was an amoxicillin-based regimen. Amoxicillin is fantastic for H. pylori. You can't assume those high success rates will just transfer over to LTT or even BQT. Your allergic patient is a different clinical scenario.
That makes a lot of sense. What about judging success? This seems like a common trap.
Oh, this is a major one. Do not, under any circumstances, judge success based on symptom resolution alone.
Because the heartburn might get better, but the bug is still there.
Exactly. Remember, both regimens include a PPI. The PPI will suppress acid and make the patient feel better whether the bacteria are dead or not.
So symptoms are a totally unreliable proxy for eradication.
Completely unreliable. You have to test for cure.
A urea breath test or a stool antigen test.
Yes, and timing is everything. You need to be off antibiotics for at least 4 weeks and off the PPI for at least 2, otherwise you risk a false negative.
What about the fear of side effects? You hear quadruple therapy and you just assume the patient's going to be miserable.
Don't let that fear drive your choice. We talked about this. The safety profiles are generally comparable. The side effects are different. Metallic taste with metronidazole versus tendon issues with levo. But overall tolerability is similar. Don't let the fear of side effects push you to a less effective drug.
Just warn them about the black stool from the bismuth so they don't panic.
Exactly. Tell them what to expect and they'll get through it.
And lastly, what about rescue therapy? If a patient gets LTT and it fails,
Do not re-challenge with the same class. If LTT fails, you've likely induced resistance. You have to change your mechanism of attack.
so you switch to BQT.
You move to BQT. It's the preferred rescue therapy,
Yeah.
which again reinforces why starting with BQT is often the smarter move in the first place.
So let's try to summarize the comparative efficacy. When you strip it all down, who wins the fight?
The consensus, when you weigh all the meta-analyses, is that Bismuth Quadruple therapy generally achieves higher eradication rates than LTT.
It's the heavyweight champ.
It is.
Yeah.
Especially out in the real world where resistance is all over the place. Efficacy goes to BQT. Safety, it's about a tie. Symptom improvement, also a tie. But for the primary goal killing, the bacteria BQT has the clear edge.
Okay, let's distill this down to a practical clinical algorithm for everyone listening.
Sure. Your default posture, your starting line, should be Bismuth Quadruple therapy. Especially if you don't know your local resistance rates or you know they're high. It's your most robust choice.
And the exception to that rule.
You reserve levofloxacin-based therapy for a very specific subset of patients. Those where you have confirmed low local resistance, and there's a significant real barrier to BQT, like a major adherence problem.
Even then,
Even then, you have to weigh their age and renal function very carefully.
it's almost like you have to earn the right to use LTT.
That's a great way to put it. You have to qualify for it. You don't just get it because it's easier.
Before we wrap, I want to leave everyone with a final thought. We've talked so much about resistance patterns being the key.
It really raises a point about surveillance. We often practice in this little bubble, just treating the patient in front of us. But this specific dilemma shows how much we depend on the bigger picture.
The public health data.
Exactly. Knowing your local biogram, your community-specific resistance rates, is the key that unlocks the simpler regimen safely. Without that data, you're flying blind.
So the most important tool in your kit might not be a guideline, but your local antibiogram.
It just might be a powerful reminder that good public health data drives good individual patient care.
Well, that's all the time we have. Hopefully this clarifies the decision matrix for your next penicillin allergic patient with H. pylori.
Keep an eye on those resistance patterns and always verify the cure.